So I'll just speak about PMTCT and then end up with where Busoga starts at the moment, as I was introduced. My name is Dr. Linda Nabitaka. I work with the Ministry of Health, the AIDS Control Program. Okay, so I'm not so sure the audience I'm talking to, so I'll speak both like I am talking to people that know PMTCT and then talking to people that are new to PMTCT. So some of the slides are really about, they will be very technical, but a number of slides will also go to anyone who is hearing about PMTCT for the first time. So globally, we know that about 90% of all children with HIV will have got it from their mothers, either during pregnancy, delivery, or breastfeeding. There are very few, about 10%, who get it through rape and other means, a very small number, but for most children that are infected with HIV, they actually get it from their mothers at those different time points. And in Uganda, this transmission of HIV from mother to child accounts for about 15% of all new infections. In Uganda, we've seen a lot of progress in the elimination of mother-to-child HIV transmission, with over 140,000 children saved from getting HIV from their mothers in all the about 22 years of implementation of PMTCT. And because of HIV testing and giving treatment to mothers, we've reduced the early mother-to-child transmission rate to about 2.9%, while transmission at the end of breastfeeding is at about 5.8%. And the number of children getting infection from their mothers has reduced from 25,000 that it was in 2009 to about 5,320 in 2020. I don't know, everyone I think will see this as in a different picture. A number of people, when you talk about 5,000 infections from mother to child, some think, oh, we've done a big job. Quite a number of other people still feel that there's a lot to be done. 5,000 per year is quite a big number of infections, especially in children. It gives such a big burden to the country in general and to the mothers who are having those children who are infected with HIV. We also know that maternal syphilis, once a mother has syphilis during that time of pregnancy or breast pregnancy, they can also pass on congenital syphilis to their children. And this causes quite a number of issues with the children, including stillbirths and neonatal deaths and many effects for the children. And yet syphilis testing and treatment coverage in Uganda is still about only 77%, and hepatitis B is at about 26%. And we know that most people who ended up with chronic hepatitis B are people that acquired it perinatally. And HIV, syphilis, and hepatitis B are basically transmitted in the same way. So there's now what they call the Global Triple Elimination Agenda that is supposed to ensure that all children are given the greatest chance to start a healthy life, that is free from the 3 preventable diseases, because they are transmitted in the same way. And the Maternal and Child Health Platform offers a very good platform for us to implement that triple elimination agenda. So this agenda has certain targets at both process and impact level. So at impact level, we want to ensure that less than 50 cases of children are born with HIV or syphilis, meaning that we have a transmission rate of less than 5% in a breastfeeding population like Uganda, and less than 2% in other populations that do not breastfeed. While for hepatitis B, means that we have antigen below 0.1% in children below 5 years, and a 90% reduction in 5% reduction in mortality. The side of process, that means that we need to test 95% of all women with syphilis and hepatitis, and then give treatment to all to over 95% of women who test HIV positive or have syphilis, and those who have hepatitis B. But also for syphilis, we add the issue of immunization to both the mother and the baby. So what is the distribution of new infections in children in Uganda? Where do these new infections, where are they majorly coming from? So every year in Uganda, we do what we call the spectrum estimates, and then try to put in numbers and try to model and see, where most infections are coming from. So as of 2020, 34% of new infections in children were coming as a result of mothers who started on ART. However, they stopped. 18% stopped while still breastfeeding, while 16% stopped, 18% stopped while pregnant, while 16% stopped while breastfeeding. And then 30% of new infections as a result of mothers that are getting HIV infection are new, either in pregnancy, 9%, or getting HIV infection while breastfeeding, 21%, while 23% of infections were coming from mothers who do not start ART at all, who do not take ARVs at all. And we've also known that mother-to-child transmission is highest in the young women, 15 to 24 years old. And so essentially, those are the three areas that are still causing us a problem as the PMTCT program. So these are the goals of the PMTCT program in general. We want to ensure that we reduce mother-child transmission of HIV, syphilis, and hepatitis B by 95%, by ensuring coverage of both testing for HIV, syphilis, and hepatitis B, testing and treatment, by ensuring that there's no unmet need for family planning, and ensuring treatment, 95% treatment, support and retention in care for all mothers that have HIV and hepatitis B, as well as care for the HIV-exposed infant and the rest of the family. So just as a reminder, how does HIV transmission from mother to child happen? And how, where, and how. So we know that even without any intervention, only 25 to 35% of HIV positive pregnant women will pass on HIV to their babies. About 63% of them, whether there's intervention or not, they will not pass on HIV to their babies. 30% of this will occur during a pregnancy, and about 70% will occur during that time of delivery, while transmission during breastfeeding will range from about 14 to 90%, and is increasing over time due to various issues. So what are the transmission risk factors? So in pregnancy, transmission will occur if the mother has viral, bacterial, or parasitic infections, especially which affect the placenta, making it porous and making infections cross through the placenta. It will also occur if the mother gets their infection for the first time during pregnancy. It will occur if the viral load is high. It will also occur if the mother does not take ART or is not adherent, and it will occur if the mother has a severe immune deficiency, if their immunity is not good enough, because that means then there's a lot of virus in the blood and it will cross over to the uterus and therefore infect the baby. While in labor and delivery, it is affected by duration of membrane rupture. It will occur if there's acute infection of the placenta membranes, like in chorioamnionitis. It will occur if there's invasive delivery techniques, like what we used to do, the forceps delivery, or all those invasive techniques. It will occur if the mother's immunity is low, shown by a low CD4 count, and also if the mother has severe clinical disease. Then in breastfeeding, usually the exact timing of transmission is difficult to determine, but also HIV seems to pass in the blood that goes to the breast milk. So the virus may also come directly from infected cells within the breast, or through the blood that goes into the breast milk. And this can be determined again by the mother's immune status, if their CD4 is low, or the mother's viral load, if they have a very high viral load, or the breast milk viral load may also be made higher if there is a recent infection during the time of breastfeeding. And it's also greatly affected by breast health. Any condition of the breast that disorganizes the breast can also cause the virus to pass through the blood and into the breast milk and finally into the baby. Then maternal nutrition status, the infant age, the more, if the child is premature, then their mucosal membranes are very, very thin, and it's easier for the virus and, to pass from the mother's milk into the infant. Then mucosal integrity of the mouth and its intestines is very important. Therefore, things like diarrhea, anything that affects the mucosal integrity is also very important for transmission. Then duration of breastfeeding is also very key, because we've already seen that the virus passes into the breast milk itself. So the longer one breastfeeds, the more the possibility of transmission from mother to child. But also we need to balance this out by ensuring that the baby gets the nutrients that they need. And we know that breast milk has all the nutrients that a baby needs. Then the pattern of breastfeeding is also very critical, whether the mother does exclusive breastfeeding or mixed feeding, because as we know, mixed feeding can affect the mucosal integrity, both in the mouth and intestines, and improve and increase the chances of transmission from mother to child. We also know that with proper care, only one baby, like that one in red, will get an infection from mother to child out of 20 babies. But even without any intervention, no PMTCT intervention, only 6 babies would basically acquire infections from their positive moms. So even if no infections were done, no interventions were done at all, we would still have 14 out of 20 babies coming out without HIV. With proper care for the HIV positive mothers, this reduces to only 1 out of every 20 babies. And what do we mean by proper care for the mother? The mother being started on their ARVs and adhering to it throughout pregnancy, throughout breastfeeding. This means the mother getting tested and treated for any sexually transmitted infections, because we know The sexually transmitted infections will affect the placenta and therefore increase the risk of HIV passing through. This means using safer conception methods that lower the risk of infant and partner transmission. It also means delivering the child in a setting where the mother and child can be given sufficient care. And most important of all, this means enrolling the mother into the PMTCT program and the child into the HIV-exposed infants care program. So what is it we need to do to reduce mother-to-child transmission of not only HIV, but of all those sexually transmitted diseases? We need to prevent new infections in women of childbearing age. We need to ensure that women living with HIV only have a baby when they are ready to have a baby. So if they are not ready, then we need to avoid any unintended pregnancies. Then for the women who are living with HIV and are ready to have a baby, we need to offer them all the services available that can prevent them from passing on HIV to their baby, as we saw. Give them ARVs, make sure their viral load is well monitored, make sure that they are breastfeeding when they are healthy, treat all STIs, care for both the mother and the child and the husband. All those different things ensure prevention of mother-to-child transmission that is reduced. Therefore, we need a wide scale of service coverage, and as well as uptake of the interventions, as well as quality services in order for us to close the different taps and ensure that no children are born with HIV. And this is what translates into the four-pronged approach of WHO and UNAIDS, which includes the primary prevention, making sure that women of childbearing age do not acquire HIV infection at all, making sure that those that are HIV infected already do not get unintended pregnancies, doing all the services for prevention of HIV transmission from mother to child, for the women who are pregnant or breastfeeding and HIV positive, and then providing the appropriate treatment, care, and support to women living with HIV, as well as their families. So what has the country done to date to reduce mother-to-child transmission? We have scaled up PMTCT services to over 3,600 facilities across the country. So out of the about 4,200 facilities across the country, 3,600 of those are able to provide PMTCT services, including some health center tools. We have trained and retrained health workers as needed in line with the policy changes, as we are going to see the policy changes. We have ensured commodity and resource availability for program implementation through different resource mobilization and working with our partners, including all the AIDS development partners, WHO, UNICEF, UNAIDS, UNFPA, and most importantly, PEPFAR, that is covering the biggest part of the country. We have revised and reviewed guidelines in line with the WHO guidance. So whenever there's a change in the WHO guidance, according to research and new innovations, the Ministry of Health then reviews the guidelines and improves implementation. We have done support supervision, quality assurance, M&E, and performance reviews. We have improved laboratory services, including viral load measurements, to make sure that our mothers are pregnant and breastfeeding with well monitored and suppressed viral loads, and introduce point of care technology for testing, including the HIV exposed infants. We've also worked with leaders at all levels and all across board, culture, religious, and political, for advocacy for service utilization and uptake, and also worked with all the different community resources including the village health teams, peer mothers, and family support groups, to make sure that mothers access PMTCT services and stay in care throughout the PMTCT cascade. And the program has had a lot of milestones. The PMTCT was launched in about 2000, and since then, there have been quite a number of milestones. The first guidelines were developed in 2002. The guidelines were revised in 2006 in line with the WHO guidelines and improved in the way services were implemented. In 2007, we started the early infant diagnosis using DNA PCR and the central lab in the country. In 2008, we did a situation analysis of the program and then developed the third edition of the guidelines in 2010. In 2011, we developed our first elimination plan in line with the first global plan, and then continued to improve the guidelines in 2013 when the option B plus or test and treat strategy was developed, was released by WHO. In 2017, we had a joint review of the HIV and PMTCT program and had an impact assessment and validation on the path to elimination in 2018. And after that, we developed the National Elimination Plan for mother-to-child transmission of HIV, syphilis, and hepatitis B, which is that guiding document that we are using to date. And as we can see from the pictures, we've had trainings for health workers. We've developed the different guidelines that you can see. We've had support supervision, and we've continued to support the health facilities as is needed over time. At the same time, we worked with the First Lady as the champion for mother-child transmission to carry out countrywide campaigns in order to get people to utilize the PMTCT services, and also to introduce the Free to Shine campaign, as well as the Bringing Back Mother and Baby into Care interventions in line with the four-pronged approach of PMTCT. As you can see here, the First Lady, together with the then UNAIDS country director and the ministers of health and the American ambassador, were launching the Free to Shine campaign and the campaign to keep mothers and babies in care. And we had quite a number of participants from the districts coming to listen to what that campaign meant and supporting us to continue to implement programs. Here we did, this is showing the different regional campaigns that we went to with the First Lady. We started with the Southwestern region. We did Eastern region. The last one, the Mid-Eastern, is actually a campaign that happened in Jinja, bringing together all the leadership at the district level, as well as other community actors, to understand what PMTCT program is and encourage mothers to come for the services at the facility level. Okay. We've also done several behavior change communication campaigns. As you can see here, wife and husband being encouraged, husband to support the wife during pregnancy so that they can have an HIV-free baby. Mother is talking about taking her ARVs, again, to have an HIV-free baby. Mother is talking about coming back to the facility as advised by the health worker throughout the PMTCT and EID campaign, again, to ensure that they remain HIV-free. And then this booklet that was made for the different set of leaders, whether political or religious or cultural leaders. This booklet was supposed to support them to understand what PMTCT program means and what their role was. And the major theme is that it's time to eliminate mother-child transmission in Uganda, and therefore no child should get HIV from their babies. So basically, they were supposed to be able to identify available support groups and refer the mothers, commit more resources, and support to retain health workers, mobilize communities for EMTCT services, help the community to appreciate the importance of starting ARVs and remaining on their ARVs, mobilize men at all levels to participate in healthcare services, especially PMTCT, advocate for Parliament to denounce all forms of negative culture or practices and sensitize population, as well as enact laws that are conducive, and then mobilize resources and follow-up mechanisms to ensure prevention of mother-to-child transmission. The program also introduced the HIV syphilis duo testing that at one sitting and on the same day provides testing for mother for both HIV and syphilis and ensures that a mother is able to start treatment for the same. So this HIV syphilis duo within 20 minutes and at one sitting is able to show the mother and the husband whether they have HIV and syphilis, and therefore start off the treatment. At the same time, we also launched the campaign to eliminate all other communicable diseases from being transmitted from the mother to child, including HIV, syphilis, malaria, hepatitis B, so that basically children are born free of all the different diseases. And this is a picture of us training health workers on how to test for all the different infections and making sure that mothers provide the appropriate treatment. So where do we stand as of now? So as of now, about 89% of mothers attend antenatal. However, very few of them attend at the time that we would have wanted them to come. So only 36% attend in the first trimester. Most of them are coming late, while only 59% attend up to the fourth visit. It is very critical for the mother to be retained in care so that they can get all the services until the end of the pregnancy, but quite a number of mothers are not coming back for that. 98% are getting tested for HIV, and out of those that should be retested, because testing is at the first antenatal, again in the third trimester and labor, only 31% are getting retested, while syphilis testing stands at 85%, and hepatitis B testing at only 19%, and only 25% of male partners are coming with their pregnant partners to know their status. So basically our gaps as a program are attending antenatal during the right time for us to be able to provide all the services, continuing to attend antenatal beyond at 4 visits and beyond 4 visits, retesting for those that might seroconvert. We saw in the first slides that the biggest problems now are coming from mothers who seroconvert during pregnancy and breastfeeding, and then end up passing HIV to their babies. And then hepatitis B integration is still very low. And then we have issues with the partner. As we know, these are sexually transmitted infections. So it is critical that you not only know the status of the mother, you need to know the status of the partner so that you interventions are given to both the mother and the partner. So when it comes to the mothers who are HIV positive, at least about 95% of them are getting ARVs for those who are HIV positive. 77% of those who test positive for syphilis are getting treatment, and for hepatitis B, it is only still 23%. So we still need to do a lot of work for hepatitis B. Then even if very few mothers are having viral load access at only 57%, almost 100% of those who are tested have good viral suppression, which is good for us. But however, only 66% of mothers are retained on care up to 12 months, which is, as we saw, a very critical issue, because if they don't stay on their ART, then they are more likely to pass on HIV to their babies. And this is the distribution of outcomes for the mothers. A big percentage of them, 12.4%, are lost to follow-up, and about 24% are moving between facilities, which makes their care very difficult. So this dashboard speaks to the whole country, where we stand as a country, and by the region. As we can see, green denotes those that are doing well above the targeted number, above the 90% target that is set by WHO. Yellow means a bit fair, above 75 but below 90, and then red are those that are really doing badly. So when you look at the national level, 98% of women are tested, 31% retested. ART provision is about 97%. And when we break down by region, Toro region seems to be doing best of all the different regions in everything. But when you look at retesting, when you look at viral load uptake, hepatitis B testing, and hepatitis B treatment, all regions are in red. Where does Busoga stand? Busoga is just below the national performance. They have almost all women tested. However, retesting is only 20%, which is below national. ART provision is at 97%, which is equal to national. Viral load is 70%, which is fair when compared to the rest of the regions. Viral load suppression is about 84%, which is not so good, because we know if a mother is not suppressed, then they are likely to pass on the virus to their baby. Retention at 12 months for women is 71%, again in the yellow. Syphilis testing is at 85%. Syphilis treatment is at 78%. We would want to see all these are moving to the 95%. Hepatitis B is at 18% testing, and then 44%, which on average translates to about 67%, which is close to what national is. What we can say is it is not in the top 5 as Busoga, but also it is not in the last 5 regions that letting the national level come down. So when we break down the Busoga region districts, this is where they stand. Iganga performs best within Busoga region, but as we can see, nationally, it's ranking at 40 out of the, is it 166 districts now? So that means we don't have any Busoga region districts among the top 10, meaning that there's still a lot of work to do. So we can see the things that are really letting us down: retesting mothers, viral load, taking off viral load samples, returning the results to the mothers, retention, hepatitis B testing, and treatment for hepatitis B. We know that the hepatitis B is a new thing, but the fact that the country has moved to triple elimination, we all need to see how we can support to make sure that these services are fully ingrained on the maternal and child platform and are implemented well. So Kaliro comes second in the region. It's 47 nationally. Namutumba then comes third. It's 50 across. Then Buyende, Kamuli, Luka, Bujiri, Namayingo, Jinja, Mayuge, Bugweri, and then Jinja City. Probably because now for the first time we are pulling out performance for the city as a city, we are now coming to understand how complex it is to implement within the urban regions, and probably need to support Ginger City to also get up to scratch and be able to provide services to its inner city population. But also it is probably compounded by the fact that many women are coming from the different areas and coming to the regional referral within the city, and that kind of overwhelms the city service provision and brings it down. But this is where we stand as Busoga region, and clearly we can see there's a lot of work that still needs to be done almost across board for us to reach to achieve mother-to-child transmission. What about the HIV-exposed infant services? This is how the performance is nationally. Almost 100% of infants are given ART for prophylaxis. Only 87% access a first test, 77 of those within the 2 months as recommended by WHO. Only 67% access a second test at 9 months, and only 65% access the third test, which would now actually tell us that the mother the babies are totally HIV negative. So for quite a number of babies, we care for them, but they don't reach the final test. So we don't know finally what happens to them. Good enough, only 2% out of all the babies tested are testing HIV positive. So most of the babies, when tested, are coming out HIV negative. If only we were having 100% testing at the third DNA PCR, then we would be very happy with where we stand. We would know that we are moving towards elimination. Then this is when we look at the birth cohorts, and this helps us to actually look at the final outcomes of the infants. Again, you can see only 76% are discharged at 18 months, meaning that we don't know what happens to the other 24% of the babies. They get lost along the way, and we don't know what happens to them. And only 64% are exclusively breastfeeding, and the rest of the outcomes, as we can see in the graphs. And where do we stand as the national level in exposed infant services? As we can see, almost all of us are not doing well, both in testing for the HIV exposed infants, but as well as providing them quality care, including including cotrimoxazole prophylaxis, giving them nevirapine prophylaxis, as well as discharging them out of care. And where does Busoga stand? Again, when we look at national level, Busoga is giving about 84% of infants prophylaxis. Again, it comes below the national level performance. This time it's about 1, 2, 3, 4, 5, 6. It's about the 8th. 84% of infants are given prophylaxis. 63% are given septrin prophylaxis. 50% within the right time. And nevirapine uptake is about 72%. Testing the babies is about 79%. Yeah, that's so. Yes, 72%. First DNA within 2 months is about 79%. Cotrimoxazole 75%. 74% DBS. Second DBS. Only 72% are discharged at the end of 18 months. General average of about 71% as Busoga region. So we can see that when you rank it with all the other regions, Toro, Bunyoro, Kampala, North Central, Kigezi, Ankole, Lango, South Central, we are still not doing very well. Even if we are quite above the West Nile, Karamoja, and Teso region that are performing rather poorly. And then within Busoga region, now for the side of the exposed infants, Namutumba is performing best, but ranked 39% nationally. Now here, Jinja City, comes up second, but ranking 46% nationally. Then followed by Luka, Iganga, Kaliro, Bugweri, Kamuli, Buyende, and Namayingo now ranks the worst in offering services to the HIV exposed infants. Again, this is looking at the birth cohort outcomes, still basically ranking poorly. So what are the key issues within Busoga region? High rates of teenage pregnancy due to issues of school dropout, illiteracy, and poverty. We've already seen that there is low utilization of services. We saw mothers are coming late. Quite a big number of them are not getting retesting. Quite a number of them are not receiving syphilis testing, as well as hepatitis B testing. There are issues of loss to follow up due to self-stigma in the mothers, as well as denial. Male involvement is not doing well within the region, and yet we know that if the male partner is supporting the wife fully, then they are more likely to fully access services and be retained in care. Gender-based violence is still a big issue, including violence against children. We have a big number of immigrants and had to reach communities within the Bunia sub-county, as well as many fisher folk within the district. And we know that these ones, they don't stay in one place, and that makes offering services to them very difficult. And then we find that quite a number of many districts within the region have many health center tools, and yet the MOH policy for MCH and PMTCT services stops at health center 3s. And this makes it difficult for all the women within the region to therefore access services. We have to, do many different innovations for us to make sure that all the women access services. So in conclusion, we all know that it's every child has the right to start free of all the communicable diseases, including HIV, effects of syphilis, hepatitis B, and any other transmissible diseases. And all of us should somehow stand up and be counted and work together to ensure that we have a smile on all these children's faces, especially when they are born free of all the different illnesses. Thank you very much. That ends my presentation. Over back to you, Alan.